Hi everyone, I'm Sir July, and for this slide sets, we will be discussing malaria. Malaria is a serious and sometimes fatal disease caused by a parasite that commonly infects a certain type of mosquito which feeds on humans. It is endemic in the Philippines. There has been improvement in the prevention and control though, as seen in this slide. This old map shows the geographical distribution of malaria in the Philippines. Presently, or at least last 2019, according to the DOH, there are only 4 provinces that remain endemic for malaria as the country races to be declared malaria-free by 2030. These 4 provinces are Palawan, Sulu, Occidental Mindoro, and Sultan Kudarat. This slide shows the shrinking number of cases of malaria in the Philippines. Sickle cell trait provides natural resistance to malaria. Patients with the sickle cell trait have a six-fold reduction in the risk of dying from severe falciparum malaria. This is so because infected RBCs containing hemoglobin S exhibit reduced cytoadherence. Malaria is caused by parasitic species of the Plasmodium genus. It includes P. falciparum, P. vivax, P. ovale, and P. malariae. Most commonly, malaria is caused by Plasmodium falciparum. In addition, Plasmodium falciparum also causes the most serious type of malaria because of the high parasitic densities in the blood. There are periodic reports of simian malaria parasites being found in humans, most reports implicating P. knowlesi. At the time of this recording, it has not been determined if P. knowlesi is being naturally transmitted from human to human via mosquito without the natural intermediate host, macaque monkeys. Take note as well that in comparison to dengue, which is caused by a virus, malaria is caused by protozoan. Depending on the species, it takes about 7 to 40 days for the symptoms to appear following inoculation by the mosquito. The incubation period of malaria is a minimum of 7 days. If fever occurs before the 7th day following exposure in an endemic region, it is most likely not due to malaria. The vector is a female Anopheles mosquito that transmits the protozoa through bites. These mosquitoes are night biting, and the predominant species depends on the region. In Southeast Asia, the predominant species are Anopheles ditrus and Anopheles minimus. In the Philippines, the principal vector is Anopheles minimus flavirostris, which breeds in clear freshwater streams in foothills and mountain slopes. These mosquitoes are night biting. To summarize thus far, dengue, day biting, filaria, between dusk and dawn, and malaria, night biting. I actually have a mnemonic to remember that the malaria causing mosquito is night biting. It's corny though, and it may not be to everyone's taste. So I just remember malaria starts with letter M, and another word that starts with letter M is the moon. And moon reminds me that it is night. Therefore, malaria is caused by a night biting mosquito. Yeah, I told you, it's Other modes of transmission include blood transfusion, organ transplant, shared use of needles or syringes contaminated with blood, and by transplacental route. This slide shows the life cycle of the plasmodium. You do not actually have to memorize this, I just want to show you some important points. The malaria parasite life cycle involves two hosts, mosquitoes and humans. During a blood meal, a malaria-infected female Anopheles mosquito inoculates sporozoites into human host. These sporozoites infect liver cells. They mature into schizons which rupture and release merozoites. Of note, in Plasmodium vivax and Plasmodium ovale, a dormant stage known as hypnozoites can persist in the liver and cause relapses by invading the bloodstream weeks or even years later. After this initial replication in the liver, the parasites undergo a sexual multiplication in the erythrocytes. Merozoites infect red blood cells. The ring-stage trophozoites mature into schizons which rupture releasing merozoites. Some parasites differentiate into sexual erythrocytic stages. Blood stage parasites are responsible for the clinical manifestations of the disease. Point 1. The infective stage is the sporozoite, and the diagnostic stage would be the trophozoite ring within RBCs, schizon containing merozoites, and gametocytes in peripheral blood. Point 2. The plasmodium life cycle involves the liver and the RBCs. As such, manifestations of this disease may involve these two organs. For example, a patient may present with hepatomegaly. In addition, anemia results from hemolysis. And my third and last point, blood stage parasites are responsible for the clinical manifestations of the disease. Patients with uncomplicated malaria usually initially presents with headache, malaise, or myalgia. In countries where cases of malaria are infrequent, these symptoms may be attributed to influenza, a cold, or other common infections, especially if malaria is not suspected. Conversely, in countries where malaria is frequent, residents often recognize the symptom as malaria and treat themselves without seeking diagnostic confirmation. According to CDC, the following are the common symptoms: fever, chills, sweats, headaches, nausea and vomiting, body aches, and general malaise. The classical but rarely observed malaria attack lasts 6 to 10 hours. It consists of a cold stage, a hot stage, and a sweating stage. The manifestations for each stage are actually obvious. For instance, during the cold stage, the patient feels cold, so the patient is shivering. During the hot stage, the patient has fever. And during the sweat stage, the patient sweats and the body temperature returns to normal. As previously mentioned and emphasized in the life cycle of Plasmodium, this classical attack of malaria coincide with the cycles of RBC destruction. The stages of the classical malarial attack is like being in a relationship. Sometimes it starts with being cold, and then hot, and then sweat. To re-emphasize, the malarial attack coincides with the cycles of RBC destruction. This results in an intermittent fever, the interval of which differs among the species. For instance, for P. vivax, P. ovale, and P. falciparum, the intermittent fever occurs every second day and they are termed tertians, and for P. malariae, the fever occurs every third day and it is referred to as a quartan. This illustration will drive the point further that the RBC destruction will result into the paroxysms. PE findings include elevated temperatures, perspiration, weakness, and large spleen, mild jaundice and large liver, and increase in respiratory rate. If a patient manifests with malaria with positive parasitological tests, either by microscopy or RTD, with no features of severe malaria, then that patient is said to have uncomplicated malaria. Symptoms of severe malaria includes cerebral malaria, severe anemia, hemoglobinuria, ARDS, abnormalities in blood coagulation, hypotension, acute kidney injury, hyperparasitemia, or metabolic acidosis. Severe malaria is considered a medical emergency. In Plasmodium vivax and Plasmodium ovale infections, patients having recovered from the first episode of illness may suffer several additional attacks, known as relapses, after months or even years without symptoms. These relapses are caused by the hypnozoites. For diagnosis, malarial smears are considered the gold standard. Malarial smears could either be thick smears or thin smears. For thick smears, it is mainly used to detect infection and to estimate parasitemia. For thin smears, it is used to identify malarial species, quantify parasitemia, and recognize parasite forms like schizons and gametocytes. In short, for thick smear, it is used for quantification, and for thin smear, it is used for a species identification. As a nice to know, thin smear findings include trophozoite ring within RBCs, schizon containing merozoites, and gametocytes in peripheral bloods seen in P. falciparum. RDT or rapid diagnostic test is used to diagnose malaria in areas or facilities where good malaria microscopy is not available. Other labs include complete blood count, which may reveal anemia and thrombocytopenia, and metabolic panel, which may reveal hypoglycemia, renal abnormalities, and elevated indirect bilirubin and transaminases. In case of cerebral malaria, lumbar tap is also done. The objectives of anti-malarial treatment are to prevent severe malaria and to interrupt transmission via anopheline vectors. Management includes supportive measures as well as specific anti-malarial drugs. This includes quinine, chloroquine, cotripazide, primaquine, doxycycline, mefloquine, and hydroxychloroquine. First-line treatment recommendation for malaria according to the National Malarial Control Program are as follows. I don't think that you have to memorize the treatment for each species and as to whether the case is uncomplicated or severe. At the very least, you must be able to recognize that the following drugs are antimalarial: artemether lumefantrine or AL, primaquine, artesunate, and chloroquine. Response to treatment must be monitored with daily blood film microscopy until the end of administration of first-line drugs, then weekly until the 29th day after the start of treatment. According to Mosby's comprehensive review of nursing, nursing management of patients with malaria include the following: monitor fluid and electrolyte balance and maintain hydration. Use therapeutic measures to decrease fever such as fluids, tepid bath, light clothing, and hypothermia blanket if ordered. Maintain bed rest until fever and other clinical manifestations have ceased. Support natural defense mechanisms such as encouraging intake of nutrient-dense foods and foods high in immune-stimulating nutrients. Lastly, reinforce importance of medication regimen. The ABCD approach to prevention includes awareness of risk, bite prevention, check whether you need to take malaria prevention tablets, and diagnosis. In the Philippines, I have previously encountered this mnemonic: clean, C for chemoprophylaxis, L for larva eating fish, E for environmental sanitation, A for anti-mosquito repellents, and N for neem tree and oregano. I tried looking for the source of this mnemonic, but I was not able to. For the chemoprophylaxis, doxycycline is given 2 to 3 days prior to travel. It is continued up to 4 weeks upon leaving the area. Mefloquine could also be used, and it is started 1 week before travel and continued weekly up to 4 weeks after leaving the area. Take note, mefloquine is the only prophylaxis permitted in pregnancy. That ends our discussion for malaria. Pause this video, gather your thoughts, and when you are ready, let us have a practice test. Which one is not true regarding malaria? A. The mosquito that serves as vector is night biting. B. The causative agent is a virus. C. Most commonly caused by P. falciparum. Or D. It can be transmitted transplacentally. You have 5 seconds. The answer here is B. The causative agent is a virus because it is caused by protozoa. Which mosquito genus is associated with spreading the human malarial parasite? A. Culex, B. Aedes, C. Anopheles, D. Lutea. You have 5 seconds. If you answered C. Anopheles, you are correct. Paroxysms occur in pattern, which correctly illustrates this. A. Cold hot sweating, B. Hot sweating cold, C. Cold sweating hot, D. Sweating cold hot. You have 5 seconds. And the correct answer is A. Cold first, then hot, then sweating. The gold standard in the diagnosis of malaria is A. Blood smear, B. Serologic test, C. CBC, or D. Culture. You have 5 seconds. And the correct answer is A. Blood smear. If you got 4 questions correctly, you did a good job. If not, rewind this video to check your answers. This ends the slide set. Please do not forget to subscribe to my YouTube channel, Memory Aid Nursing. Thank you.